Hi, this is Scott Ellis, a foot and ankle orthopedic surgeon from the Hospital for Special Surgery. We're getting ready to do a surgery that I'm going to video and hopefully show and teach you some things. It is a total ankle replacement in a patient with end-stage ankle arthritis, although also has a club foot. So a couple challenges I can predict right off the bat. She had a previous Achilles lengthening, and I know the ankle is going to be a little tight. In addition, she has a relatively small foot, the way the foot develops, so it's on the small size of the total ankle. And also the morphology of the talus in these cases and clubfoot is very unusual, so the talus is pretty flat. So I'm just going to have to be really careful about how much talus bone I take. I've used the patient-specific instrumentation to map this out, and I'm going to use a stemmed implant. So I hope you learn a lot.
All right, when we do the exposure, it's an anterior exposure. You go through the skin, subcutaneous tissues. You can see right there, I'm looking at branches of the superficial peroneal nerve, and they come from lateral across medially, and distally, inevitably, there'll be a branch. You can see I just took that I have to sacrifice or take out. It looks like there may be even a little, another one, because if you don't, then you're going to stretch the nerve and probably end up injuring it anyhow. So leave its main branch. I do tell patients they're likely going to have a little patch of numbness on the medial aspect of their ankle. And it's not going to go away, but it's not functionally a problem. So I'm showing you the branch there. I'm going to have to take as well because it will literally just be in the way. I'm not taking the main branch, but I'm just taking that little branch to the medial side of the ankle. There's debate whether you do it with electric cautery or scissor. I just tend to do it sharply with scissor. You could do knife. I haven't seen a problem with pain. And when you educate the patient and set the expectation ahead of time, it has not been an issue. I make a little rent in the center of the extensor retinaculum, and then I just use a scissor and slowly but surely come down over and head distally. This is generally between the interval between the anterior tibial tendon and the EHL tendon. You have to be a little careful not just to follow the interval all the way down, or you're going to get too medial because those tendons head medial. But once you get through the retinaculum, then you can see the tendons. I generally will free them a little bit more from their sheath, as you can see I'm doing now. But I am in between the anterior tibial tendon, which is, and this is the left ankle, which is on the medial or right side there, far away from us. And then the other retractors on the EHL, which is in the near ground. Now we're going through some fat. Basically, I go slow through here. The neurovascular bundle will lie more laterally and generally under the EHL. And I just slowly but surely go over this fat area. There will be a number of crossing vessels that come from the deep bundle. Like, for example, I think that maybe that's one. We're actually not cauterizing that, but there's one. So just cauterize those carefully because it prevents bleeding and also lets the main neurovascular bundle just come over to the lateral side. And just take your time. What we're doing is getting down to the capsule layer so that we can do a direct exposure electrocautery through the capsule. Just other vessels there. Generally have one assistant helping hold some retractors, and if you have a second, they can help you with electrocautery. But just go nice and slow to find branches of that bundle. Some cases where there's been previous trauma or scar, it makes this anterior approach harder and slower, but just take your time. Now I'm scoring centrally over the capsule with electrocautery. That is because as I do the patient-specific instrumentation, also it's important to take all the tissue off the bone because as you're going to see, we're going to use our patient-specific surgical nylon guides over the top. And so I just start this dissection even from the beginning with electrocautery. And I just take my time peeling that periosteum off from the joint heading, both proximally and distally, and exposing just bone. And you need to expose the bone on both the talus side and the tibia side. You can see it does darken the bone a little bit. I have not seen a problem with that. Now we're going back towards the lateral side. You're going to need to get down to the talar neck and really the talar navicular joint itself, because the nylon guide fits over the top of the talar neck. And if there's any tissue on that, it's going to push the guide up a little bit. And what I found is it's okay even to open the talar navicular joint just a little bit on its dorsal surface because you're going to repair it later. And opening or entering that joint has not seemed to be a problem. So just, again, take your time, make sure you have good bone exposure on all sides. It's key. It's also key not to take out any osteophytes, because the guide, as you're seeing right there, fits right over the top of that bone. And you can match that trial first, kind of go back and forth, look for landmarks. You need to feel what it feels or fits like as you put the guide on. There's a cut wire I put down the middle after I pin it, just to give me a sense of the axis of the tibia. Generally, this implant, which is the in bone, is lined up with the anatomic axis. So I look at that, and I'll take an X-ray, and I'll be able to see how it lines up, and I'll also compare it to my preoperative plan as well. So there it is. I'm rotating it slightly, and it looks pretty good. It looks like it's going right up the center of the tibia. And again, I'll match the plan, but if I like where it is, I've put one wire in there. You can see I'll put a second wire, which is now in, and then I'll take another X-ray. You have to rotate the image appropriately just to make sure that the long axis checking wire, if you will, is in between the distal two wires centered. That means you're in a good position. This is the lateral view. It's just going to give me a sense of the slope of my cut, and also the length of those anterior to posterior wires. The view is not quite in phos with my two wires, because otherwise you would see it as a single wire overlapping itself. But it's okay, because I have a good sense here that the wires are the appropriate length. There it is right there. And then what my cut level is going to be, because that is the top level of cut, and what the slope is. Now I'm looking at the prophecy or patient-specific plan for this implant, and you can see from the side view what it's going to look like. Now the nylon guide comes off, and I'm going to put my cutting guide on. You can see distally, I have a little saw blade in the distal talus cut, just to give myself a sense of what it's going to look like there, because you can couple these cuts, and that means you do both the tibia and talus just off this guide. There's sometimes when you use, and I mentioned it before, the nylon guide separately for the talus, but there's sometimes when you can actually just cut all four. And the key is, and this is important, you have to have that ankle completely reduced, both in AP and lateral views, or clinically front and lateral, so that when you cut, you've got the deformity corrected. That's the only time that you should couple the cuts. Once I'm happy there, I put an additional wire in the medial side of that cutting guide. The cutting guide is based off my preoperative plan, by the way, so I know exactly what size to expect. So now it's more stable. Once I'm happy there, I can then assess whether I'm going to couple the cuts or not. And that's exactly what I'm doing here. So I'm bringing the ankle up, so I'm completely in neutral. And if I'm happy there and the varus and valgus are corrected, I can couple the cuts. So now I'm putting the wires in the talus. There's two slots in that cutting guide for the talus. It's really important when you do this to go slow with that wire. It can spot weld sometimes against the metal. So if you feel resistance, either get a new wire or just go slow, but usually just get a new wire. And you want to come just through the back of the talus there. You can see there's a little resistance, and then it should go. It's a little bit more because I probably noticed that the two wires weren't of the same length. And then we check it on a lateral view. It didn't show on that view the exact length of the tailor wires, but that a lateral view will tell you. Once I'm happy with that, I'll then look at the gutters. So there's, on the distal cutting block, there's wires you can put on the medial and lateral side, so that when you do the tailor cut, you're not going to cut into the malleoli. You can see I'm looking directly at the gutters, retracting that tissue, particularly laterally, so I don't cut the neurovascular bundle. Those wires should go in advance just about the same length as the tailor pins that I just did. So now I'm going to cut it. And again, if there's deformity, then you should not couple these cuts like I'm doing here. You would actually just cut the superior cut and those medial lateral cuts as part of the tibia, take the guide off, and then place your nylon guide for the talus separately. And you're not going to see that in this case because I coupled them. But that's how you would direct your tailor cut. One advantage of coupling too is you take out the same block of bone that you're going to end up putting in with your combination of prosthesis and polyethylene. That was, if you didn't see it, a size 2. You can see that written on the side there, the cutting guide, and it's also on the top. This is the anti-rotation notch. You'll see later how that comes into play, but it's drilled through a little guide that goes into the cutting guide itself with a drill from front to back, and you got to get all the way to the back surface. I'm cutting this wire just a little bit more so it's not in the way of my saw. And now I'm going to use the shorter striker saw blade to cut. Generally, I'm going to ask the reps how long that posterior A to P length is measured off the bone or projected prosthesis, and then add in what the distance is from the saw from the cutting guide to the bone, and I get a good sense, and I can even mark it out on that saw what the distance should be on the saw, how far back I have to go, so I don't cut the structures in the back. I will cut all three, the top, the two sides here, which I will have done there with that same saw. And now I'm going into a wider saw to cut the talus. This one, I don't have a metric as well to cut the back, but you got to keep that hands free, move side to side, and just get a feel or feel the back, and you'll see yourself go through. You can also check with an x-ray. Now that I've done that, I'm going to start taking these wires out. The gutter pins I often remove with just the pliers. You can't get a wire driver on those, so I remove with the pliers. It allows, if you take those out, the whole guide to come off a little bit easier. I will remove that medial to lateral pin first, and then use a small cob elevator to almost turn or pry just gently that bone off. There's two wires in there that are still going to have to come out, but you can see the talar cut below and the tibia above. Take the wires out. I'll use irrigation periodically just to clean any bone dust, which makes the visualization a little bit better. One beauty of coupling the cuts is you can take the talus out first, and it makes it a little bit easier to then remove the tibia. Note there that I'm putting a little irrigation around there so that I can suck and just see the edges of those cuts well. Now there's this guide called a corner cutting guide I'm going to use to go through the corners of that tibia cut. Just to complete them if there's any residual bone that I didn't cut. This is an osteotome that I'm using to free up the talus. Be real careful not to make a new path. Just gently feel where the cut has been before, and just slowly work underneath the talar cut. And then you can take an osteotome, sometimes a curved osteotome, and try to lever or pry the talus out as I'm doing there. You can also get a rongeur and pull. I try not to get it piecemeal like I did there, but sometimes you do. And I don't have to get the whole talus out necessarily now either. And that's exactly what I'm doing. I'm going to wait. Now, the corner cutter guide goes in each corner. You impact it gently towards the back. You have to be really careful, especially in softer bone, to not change the angle of that cut, because you can easily dig into the bone and actually change the contour of your cut, which I've done. And then you get into trouble because you have to try to smooth the cut, and it can start changing the orientation of the cut or the joint line. So just real slow. On the back of that slap hammer, there are guides to tell you how far to go back based on your pre-op plan and the length of the projected implant, because you don't want to also put the guide into the back of the ankle either. So I will have looked at that with my assistants and gone just far enough. This is a little screw device, which I've marked off with a wire, sorry, with the marking pin there. You can see to the projected length of the implant. So I go far enough, but not too far. And then you have assistants hold the leg and foot and provide a firm force outward. And that's how you get the piece out. You have to be careful not to lever either medial or laterally, because you can fracture the malleoli, or lever too hard into the tibia. This is some residual talus bone, so I'm just taking it out piecemeal. That's the main talus. It looks like the appropriate amount of cut. It is a flat cut, and I'm just assessing the cut and making sure it looks regular, now using irrigation and suction. There is a apparatus called a jig for the stemmed implant here called the InBone that has traditionally been used. This is the guide that you use, which has a surgical nylon underside which fits on the bone just like those other guides did. and it matches both the tibia and talus side. And once I'm happy, I will, and I take a couple x-rays usually to make sure it's down and far enough in the back, but I'll put these two wires through. No, they go somewhat diagonal from distal to proximal, and you want to get just through the back cortex. Same thing here. This pin can either go in on the medial or lateral side. I generally don't put both. And we'll put it just through the front and the back. Once that's in place, I cut those distal wires in half, the proximal wire complete, and I put this little outrigger on. This outrigger is what's going to help us do the work from the bottom of the heel. It fits on the guide proximally and has a foot plate distally. Notice there's a blue towel there between the foot plate and the foot, which prevents me from pushing it up too hard and also makes it easier at the end when I'm taking that guide off or that apparatus off to have some area between the foot and the plate, and it facilitates getting it out. I've locked those knobs in place, and now the jig's in place, and I'm ready to start the approach to the bottom of the heel. I always joke that it seems crazy to consider going through the bottom of the heel, but basically we're making an aperture so that I can drive up the rods and devices used to put the implant together. That incision, so I mark it first, and then I make a little incision. It's a little bit medial, and that's because the patient probably has some valgus hindfoot. It can't be way off the medial side, but on the other hand, my experience is it's going to be a little bit medial and still be okay. You could see in a lateral x-ray where that cannula is coming up against the bottom of the foot, and there's two grooves at the tibia there, which show me where my reamer is going to go, and it looks like it's centered. So that, to me, is good. And I'm going to slowly drive up this drill. It's a relatively small drill that just makes it an opening, and I'm going to just watch myself as I go through. Go through the calcaneus, talus, gentle pressure, stay real slow. You can make small hand adjustments as you come up. I'm coming just through the guide there, and it looks centered. Once I get above that anterior to posterior wire, just above it, I'll go to an AP view to make sure I like the orientation, because this is where you're going to ultimately ream, and this is where your implant's going to go in. And even on the AP view, it looks pretty good. If I needed to move it medial lateral, I could come back slightly and make some small adjustments. It looks like maybe that's what I did here, just to come slightly more medial. You will also have an opportunity with the reamer to make some small adjustments as well, but that looks like it's pretty centered. How centered it looks also depends on exactly the rotation of the x-ray you get. I bring that drill out. This centerpiece comes out of the implant, because now I can drop my reamer tip after I irrigate into the space there. There is a tool with a threaded tip on it that I'll introduce into the ankle there, and I'll put the reamer tip on it. You can see I'm putting the reamer tip proximally through. And once I have it attached, which you have to make sure it's square also, okay? And one important point is, distally, I don't have a wire driver on that reamer tip. I'm actually using it by hand, so it's not a lot of force, because I want to feel the subtle engagement of the threaded rod onto the reamer tip. The reamer tip size is going to be told to us by the plan. So, for example, this was a size 2 implant projected. It's going to be a size 14 reamer, and each size of the tibia is going to dictate what size that reamer is. Okay, it's starting to ream up. This is a smooth cutting reamer. There's a sharp one too for harder bone. The bone wasn't that hard here. I'm just slowly but surely driving it up, make sure I'm centered. If anything, it looks a little posterior there, so I'll make some small adjustments. I can push the tibia back or have my assistant push it back, maybe aim a little anterior. Then I go to an AP again to make sure I'm down the middle. It should follow the path of the drill that you made. But if you're making adjustments with your hand, it can deviate slightly, or you can make adjustments slightly. So here's what it looks like from the side view. I'm just filling that canal. And the plan sometimes will call for even smaller stem tips, approximately but in general, I'll ream the same size. And then when I go to put the implant in, all the implant size will match that size that I reamed. In this case, it was 14, except for the most distal cylindrical piece, which will be one above, so I can press fit it. So in other words, if it's a 14, I'd put a 16 in. And you want to put in, I usually want to press fit one to give more stability, but you could press fit two if the bone is weaker. If the bone's really hard, I'd be very careful or cautious not to press fit two, because you may struggle to get that implant up or could break the tibia. Now, after we've reamed it, I'm actually putting a series of wires through the part of the foot plate that's around that distal cannula, because I'm going to secure that, because we're still going to do work through the heel, but the jig or outrigger is going to come off. I'm just showing on an x-ray where those pins are coming up. Once I'm happy with those, I will cut those just short of the working length of that cannula. And then we take the foot plate off through that area, the blue towel that I mentioned before. And then we will slide that guide off by releasing the distal jig component and then proximally releasing it off those nubs. That part can be a little tricky, so just take your time. The wires come out. I oscillate those out so I don't break it. The proximal wire is going to come out as well. I pull the metal component of the guide out, now the surgical nylon, and now the last wire. So now I've got my cuts and my reaming is done. I'm placing what's called a strike rod down the middle, and I have this, we call it a lollipop guide. It's the match for the projected size of that implant. It's got a long component and a standard on either side of that rod. I put it in there to make sure I got good coverage from anterior to posterior, which looks like I do there, and I will choose the appropriate length, whether it's standard or long, and generally the pre-op plan tells you. So now I'm going to start assembling the implant in. I generally take the tips component, which is rounded, and screw it on to the next component and put a wrench, which you see in the ankle there, on top of it, and gently with a strike rod impact it into position. I will then drop the next component down. You can see right here, which has a threaded tip. You're not unfortunately seeing the tip of it because it's deep inside the ankle there. It screws on. So this is, I'm using what's called an X drive distally. It's like a long screwdriver that I get into the center of that next cylindrical component so that I can screw it on to the component that's in the grasp of that wrench. It's really important to put one hand on the wrench, one hand on the screwdriver, so you don't turn or torque it and crack a malleolus. You can notice a subtle move there where I took the wrench, once I was happy it was tight, down a notch to the next component so that I can impact this up. And you just keep slowly assembling and moving the implant up into the ankle. I use a laminar spreader there as well to spread and gain some access so I can put the next component with the clip. Now that's a size 16. That's going to be my final base component, as I mentioned, because I'm going to press fit this. I use my X drive again to go into the bottom of the heel, get into the center of that component so I can then screw it in to the more proximal 14 millimeter component, which is currently or still being held by that wrench. You can see with this system, unlike the jig, the traditional jig, there's more play in it. So you have to use your hand and move it up to gain control. And I'm really making sure it's nice and tight there. I lower it down to the next piece. Although in this case, since it's a 16, I have to go from the 16 to the 14 to the 16 wrench. This wrench is special. You'll notice it's got a slot down the middle, and that is because when I go to put the base plate on, which has a Morse taper, there is a rod that attaches to it, it screws into it, that will bump up against that wrench, and it will sit into the groove so it doesn't hit as hard up against the flat wrench like those other ones. There's a circular notch on that last component, which I need to make sure is facing straight up and matching that anti-rotation notch that you saw that we drilled at the very beginning. Making sure that looks completely screwed together. I placed my wrench back on. And I'm going to drive that component so it's up flush with the tibia bone. See, I put a bump under the heel to make it more stable, and just gently impact that so it's up into the tibia. A beauty of this implant is that stem, it gets incredible fixation. I use 4-piece stem here. The research shows that if you use a 3, it has solid fixation into better bone and provides good long-term stability. So I think you can make an argument certainly for 3. So now I've impacted the stem into position. It looks like it's nicely centered. This is on the AP view. I'll check a lateral view too to make sure that I got it completely down. Here's the base plate going in. Again, that wrench has these slotted grooves so they can fit the handle. And the handle has the base plate with the Morse taper. It's got a roughened surface that will allow for ingrowth. You see how the handle fits nicely into that wrench. Now, real important, you see how we got a hand on that bone, and one person should hold that, or you can do it yourself, but hold it very firmly so that when you packed firmly distally, you're engaging the Morse taper, the base plate, into the last cylindrical component. But if you don't provide counter pressure, you may not seat it, or you can crack the tibia more proximally. Here it is going in. And also with that handle there, I've got to guide the implant into the notch. You can't quite see there, but I got to make sure it's flush. I'm also checking here you can see the center of that little hole there has a line through it, which is the Morse taper. That tells me if I've pushed it up into the hole, I've engaged the Morse taper. So this is a check to make sure I've engaged it enough. I've got the strike rod on it, and I'm going to get ready to impact it up, which I have here. It looks like that implant is a little posterior in terms of where the stem meets the bone, although the talus, the tibia plate itself looks quite good, and it looks flush both the anterior and posteriorly. So really not a bad alignment. You can see the talar cut below, which is going to shortly receive the talar implant in the 3 wires below that I used to connect that distal outrigger. So it looks pretty good. There's a lot of x-rays taken throughout this case, as you can tell. And we check constantly. It's a back and forth. Once that's done, I can take that whole distal outrigger off because I don't need it anymore. And the pins come out. I'm just cleaning some little extra residual bone. One key concept is making sure ultimately those gutters are clean. That's on either side of the implant, but I don't need to do that quite yet. Sometimes I'll start, but I don't need to do it quite yet. That's the talar trial. And in general, I'm either going to go the same size talus as the tibia, or very often go down 1. And I think going down 1 helps because you don't have overhang of the implant. And in my experience, and even in our research, you're much less likely to have gutter impingement. There's what it looks like on the medial lateral view, showing that there looks like there's some good space on either side. So the talus implant's not bumping up against the malleoli. And it looks appropriately sized and well aligned. You go to the lateral view because you want to make sure you're not pushing it too far back, but yet you have it centered under the tibia and have good coverage of bone on either side. Once you're happy with that, you hold it there, and you have your assistant drive these provisional small wires through the guide. And it's real important to keep that talus down in the back. The tendency is to lift your hand and have it lift up in the back, and then it's not going to sit down like it needs to. Still holding down while my assistant is actually putting the wires in. And now once the wires are stable, there's this little punch drill, which you use to put the anterior 2 pegs, which will receive the pegs from the final implant. The larger central peg, though, is probably the most important, and that's what we're about to put in here now. I take this gold handle, we call it, to take the polyethylene out at this point. so that I can then exchange the wires. But now I'm going to put a larger wire in the center hole. It's really important to keep that hand down. This ankle was a little tight. The patient had clubfoot from a child, and it just in a previous Achilles lengthening, which made everything a little tight. So it's just harder to get these pieces in and out. So I put the larger wire in. You usually advance just the subtalar joint. We'll take the smaller ones out. And one of the challenges often is to get this talus out because it's going to get held by the tibia. Now you can hold that wire. You can also take the wire out sometimes. You have to make sure you put it right back in the same hole. It's going to be a little tricky because the relationship of those wires is important. You can see I'm struggling there to get it off because of the tightness of the ankle. I actually advanced it even for that reason a little bit further down, except what happened was it slightly bent as we put it down. So we ended up taking the wire out and putting it in the hole, as I mentioned before. It's important in that case to take the last x-ray and save it so you can see exactly where it is, so that when you put this wire back in, you can take another x-ray and make sure you've matched the hole. You'll also look at it clinically. So put that in there, make sure it looks like it's where it was before. And then there's a reamer that will go over the top of that. It looks like it's exactly where it had been before. There's the one on the right before the implant came off. There's on the left. They look like they match in terms of where that longer wire goes. And now we can ream over the top. This is a Bell reamer that receives a 10mm posterior stem. And by the way, if you get like you feel like you're really close to the subtalar joint, there is a smaller version of these pegs, which actually just has 3 small pegs as opposed to this larger central peg that you can put in so that you're not coming down as close to the subtalar joint. You can just see this ankle is a little tight. Once we ream that, we'll take out the wire, irrigate it. Often I will put some bone graft in the part of the channel that was created from the bottom to the top, which is what I'm doing here. You don't want to put it in where the stem's going to go or the area, but you do want to put it in the hole that heads down towards the bottom of the foot. And my thought there is just to let some bone heal in there, so it essentially closes off any conduit or canal that had come up from the bottom of the foot through the subtalar joint. Now I've got my implant. I want all 3 of those peg positions to be laying on top of the holes that we made before I start impacting it in. And you can see that's what I'm doing. There's that yellow impactor that we're going to then put over the top to get it started. That handle that comes out the medial side is what you use to gain control and start it. It makes it a little tricky though, because it starts getting in the way sometimes, but you need it to at least start it. And that's what I generally will do. So there I am sliding it back. I'm struggling a little bit just because the ankle's tight, but we put that impactor over. We started. I take the handle off and impact it even more. And that looks like I probably used a 1 talus or a 2 tibia. It's still a little tight as I'm trying to get the poly in there. I still needed to read the gutters, and I probably would do an Achilles lengthening, although it gets tricky in her because she had an Achilles lengthening before. I do tell patients the post-op motion to expect is going to be similar to what they had pre-op. I generally don't gain a lot more. The reason to do the total ankle is really for pain relief. And it looks like it's a well-aligned implant in place well, and the talus, it looks like it's down completely. Now it is tight. Very often I will put up this medial mallet screw. It's quite easy. It's done cannulated over wire. The in bone with the stem makes it a little bit harder to get up into the canal. You just have to go to the side of it. The screw length is generally about, let's say, 42 to 50, but I believe it helps and protects that medial bone, and it's, again, so easy to do. Check AP and lateral views to make sure you're in an appropriate position, and then you can check an AP view to make sure you've finished it. This is a recip saw, we call it, that I'm using just coming off the talus, just off the medial side of the implant down, so I'm cutting any residual bone that's there. And this is important to prevent gutter impingement, but also can help with motion if you're very thorough about degrading the gutters. So I'll start with the saw. I can use some small osteotomes as well, and then I use this rongeur that I use to take out the bone, but just clear a path. It's generally big enough for that ronger, and that, in my experience, is just what you need to have enough bone and tissue out so you won't get impingement. And you got to take your time. Notice that I'm doing it with the trial poly in. I haven't put the final poly in because I don't want to roughen up the poly. I haven't made the decision on the final poly yet, but most likely it's going to be the smallest one that's available for this implant. And again, available for the downsize from the tibia down to the talus. But I won't decide on the final poly to the very end. But it's probably gonna be the smallest because the ankle's tight and I'm not gonna go up. The same process where I'm cutting just off the side of the talus. You can actually take your recip saw and cut on the inner surface of the malleoli on each side. Just careful not to cut so much where you compromise or weaken it. It's also a good reason, by the way, to put that screw in on the medial side first so that you have the malleolus on the inside protected before you're more aggressive with the gutter debridement. And some people have a plate from before on the fibula for a fracture. You can leave that too. You can see how medial my entry point was for that foot, and there was not much motion through the subtalar joint. I am doing an Achilles lengthening here. The problem is her skin was so rigid from the previous Achilles that when I went to go do this, I made a slight tear in the skin right there. So you just got to be really careful. We ended up putting a little suture in that, and she healed up without a vent, so not an issue, but it could be. And in my experience, if they've had an open Achilles lengthening, you're trying to lengthen again, it just is not going to lengthen as effectively. I'll actually then take it through some motion, dorsiflex it, and see if I can really feel that it's releasing. In this case, it wasn't releasing as much as I normally would feel just because her previous Achilles lengthening. Now I'm ready for the poly. I would have chosen the smallest poly size. There's a device that screws onto the component. And then over the top, it's got a single rod over the top. You put the guide with the polyethylene inserted, place a little set screw, and then you can advance this down. Essentially, it's going down the rails. And all those threads will come all the way down until they're completely seated. And then once they are, you back it off, take your knob out, and then you'll do your final impacting. You gotta be real careful with that. I generally leave that post so I can hold some counter. I'm going to hit it one more time. Just make sure that the poly looks like it's completely in there. You can see final x-ray showing that the implant's intact, in place, and well aligned. I'll save the final x-rays too, and I like to get motion x-rays at the end just to know for myself and to show the patient what the motion was like at the very end. And just a series of x-rays. Here's what the anterior one looks like. Here's what the final x-rays look like. It looks like it's appropriate size and well aligned. Again, the tibia stem just a little posterior. The talus looks well aligned on the talar component on the talus itself. So really not a problem. If you put it too far back, you can drive the talus back. This is just showing how I like to do betadine irrigation. It's just mixed with saline. It's about 1 liter. And we just slowly pour it around the implant, the skin, and then I clear it out with the saline wash. You can see the implant there as well. We've got a basin underneath, so it spills into the basin. This is the capsular closure. Be real careful with where that bundle is. Know where it is because you're coming through capsule, but the bundle is just lateral there. I think the layered closure is so important. This is a 0 Vicryl that I use. And I'll do figure of 8 sutures. I'll generally make it my goal to close enough capsules so that the implant itself is completely covered. You do it through a series of them. This is now a retinacular closure. The retinacular is probably the most important. You take your time. I do a 2 of Vicryl. Often I'll start at the top, then head distally. And really take your time. I like to do that before the tourniquet comes in.
Okay, so that total ankle went quite well. You saw the challenges I discussed before surgery, namely the abnormal morphology of the talus. What I did there is I actually coupled the cuts between the tibia and the talus, so I actually took a little bit less bone, and that worked out really well. The ankle was a little tight because of the previous clubfoot and the Achilles. When I lengthened the Achilles, there's a lot of scarring between that Achilles and the skin, so the percutaneous actually cut into the skin a little bit. So that's just something to watch out for. I repaired that with sutures, which I don't normally do. I was really aggressive with debriding the gutters and put a little screw up the medial malleolus, also because it's a small, tight ankle. But we used a stemmed implant. I think that's going to really help us. And everything went exactly as the patient plan told us at the beginning in terms of the size of the implant. I did use a slightly smaller tip of the stem because the canal was narrow. And on the talus side, I went down one size just to keep a little bit less material so there's not as much stiffness. But I think the plan really helped, and I think she's going to be a lot better.